We spoke yesterday about pain in a physiological nuts and bolts sense. What I want to talk about today are some more clinical and applied aspects of pain. And we'll start off, we'll talk about the attitude of society to pain and how that changes. Talk a little bit about how we assess pain and monitor pain in both a research and a clinical sense, and then talk about some of the things that we need to consider when we're treating pain. We talked endlessly about the importance of a noxious stimulus and a nociceptor, and I want to emphasize that again this morning, because when we're talking about taking pain away, about analgesia, then we're talking about the ways that these noxious stimuli are perceived. And if we can take an animal that still perceives a noxious stimulus but doesn't perceive it as an unpleasant emotional sensory experience, then we've given it analgesia, we've taken its pain away. In fact, there was a study done a few years ago looking at children that were having burns dressed, and they were going in for very short procedures, which were short but very painful, to have a dressing taken off the burn and have a new dressing put back on. And they were given fentanyl, which is a very short-acting and very potent morphine-like drug. And they were interviewed afterwards by a group of psychologists, and they said, well, was that painful? And the kids all said, yeah, that was really painful. And they said, well, didn't you mind that it was painful? And they said, oh no, it was painful, but it wasn't unpleasant, it was fine. So the morphine is allowing them to perceive the stimulus and allowing them to know that the stimulus is pain, but hey, it's taken away all that negative emotional aspect and allowing them not to suffer the pain, as it were. They can perceive the pain, but they no longer suffer the pain, and so they have analgesia. Pain threshold is the least experience which a subject can recognise as painful. And yesterday in the demonstration with the key, I took you to your pain threshold. I took you to the point where you recognised the stimulus as painful, and it suddenly became painful as the stimulus got more and more intense. So the least experience that you assess, that you say is painful, is your pain threshold. The pain tolerance level is the greatest level of pain which you're prepared to tolerate before you, I don't know, punch the person that's causing you pain in the face and run out the door or do whatever you do. It's the greatest amount of pain which you're prepared to cope with. We talked about hyperalgesia and analgesia and the difference. And just to complete the definitions, I hope, hypoalgesia is the opposite of hyperalgesia. It's diminished pain in response to a stimulus which is normally painful. And analgesia is the absence of pain in response to a stimulus which would normally be painful. This is a quote taken from a surgical textbook written by Jewell in 1900. This is as much as Jewell says about anaesthesia for animals which are undergoing spaying, ovohysterectomy. Basically, stretch the animal out on a table, tie it down, muzzle it if it's a dog or a cat, and make sure that somebody holds it firmly. And then you can do your surgery. Now that's interesting, but it's also interesting that this is quite some time after we developed the ability to anaesthetise animals. The first people were anaesthetised using chloroform and ether in 1846. And the first commercial apparatus to anaesthetise a horse was Olden's ether inhaler, which was marketed in 1847. So this is some 50 years after we first were able to anaesthetise animals. So this is not saying, well, we'd like to provide pain relief, but we can't, so we'll tie them to a gate. This is saying we don't perceive animal pain as important, and so this is all you need to do if you want to do surgery on an animal. It's a societal perception, it's not a technical limitation. This is a study that some colleagues of mine from Bristol published in 1999, and it looks at the attitudes of the veterinary profession in the UK to analgesia for dogs. They took a group of different surgical procedures, from bone fracture through cruciate to exploratory laparotomy, spay, castration, and a fairly unpleasant piece of surgery known as total ear canal ablation. And they asked the vets to rank how painful they thought those procedures would be. And you can see that the vets thought that different procedures would be differently painful for the animals. But interestingly, when they analysed this data by the year in which those veterinary surgeons qualified, you can see that the longer ago they qualified, the less painful they thought these particular procedures would be for the animals. And so I think that this reflects two things. It reflects the emphasis that we're giving in veterinary education to the importance of pain and analgesia, and I expect that over the next 2 years you'll hear a lot about analgesia and pain and the importance of relieving suffering in your animals, at least I hope you will. And also it reflects the society in which these people grew up. Obviously a vet that qualified in the 1990s will have grown up in a society much later than a vet who qualified in the 1950s. And so the attitudes of those people are being moulded by the society in which they grow up in. And what it's showing us is that as a society, at least in the UK, but there's similar data from Canada and also similar data in press now from New Zealand, in these societies we're attaching an increasing importance to animal pain and its alleviation, which I think is a good thing. Okay, so how do animals express pain? What do they do? How do we know when they're in pain? Well, first of all, and you saw this yesterday with the hammer, pain causes altered behaviour. An animal that's in pain will have an altered behaviour compared to an animal that's not in pain. As I mentioned in the practical class last week, pain causes a stress response. Pain is a stressor. So animals that are in pain will mount a stress response, which we can measure. And we can also use a variety of neurophysiological techniques, electrophysiological techniques, to look at how the central nervous system's function is changing with that pain. And an example of that I showed you in the last lecture is Craig's study looking at blood flow in different regions of the cerebral cortex in volunteers who are in pain or not. So let's have a look at behaviour then. What kind of things might we see? We might see a reduction or an increase in the expression of normal behaviours. For example, a cow that's in pain will very often stop ruminating, or rumination will be reduced. So we see there a reduction in a normal behaviour. Cows ruminate, it's one of the things they do, and when cows are in pain, they reduce their rumination. We might see an increase in the expression of certain behaviours. Cows in a field generally will swish their tails from time to time, but one of the cardinal signs of pain in cattle is that they swish their tails quite a lot. It's one of the best signs of moderate pain in cattle. If a cow's standing there and it's swishing its tail a lot, chances are it's got something sore going on. So there's an increase in expression of a normal behaviour. So now we've got a picture of an animal that's not ruminating as much as it should, and it's swishing its tail more than it might do. There are the appearances of new behaviours which animals don't express at all when they're not in pain. Going back to the cow, cows that are in moderate to severe pain very often grind their teeth. They stand there and you can hear them across the room grinding their teeth against each other. It's the appearance of a new pain-related behaviour. Vocalisation is not something that cattle do. And it gives me, well, not related to pain anyway, and it gives me a chance to talk about the difference between the prey species and the predator species. In general, animals that live in herds and are slow moving and are herbivorous and are the prey for carnivores don't show such obvious signs of pain related behaviour as the predators do. So if you look at a dog or a cat, the predator species, and you look at their pain, you will see fairly obvious signs of pain in these animals very often. But if you're a sheep in a flock of sheep and there's a wolf on the hill and you're showing obvious signs of pain, that's only going to make you lunge for the wolf. So those animals tend not to show pain as obviously as the predators. So cattle will tend not to vocalise when they're in pain. If anything, they'll go a bit quieter than they otherwise would and their normal vocalisations will reduce. But if you think of a dog that's in pain, especially if it's a little whippet or something like that, it will very often howl the place down. Yeah? So there's a species-specific change in behaviour. And so if you're looking at pain-related behaviour, you need to know what the pain-related behaviour is for that species that you're dealing with, and sometimes for that breed that you're dealing with. Again, I mentioned a whippet howling the place down, and I heard some sniggers from people who have obviously seen whippets in that situation. But if you imagine that was a stoic Labrador, say, in the same amount of pain, it probably wouldn't be screaming the place down. It would probably just be sitting quietly in a corner looking a little bit miserable. So you need to be aware of species alterations in pain-related behaviour, but also breed alterations in pain-related behaviour. And those things are they're not always related to the amount of perception of the pain. In fact, they're very poorly related to the perception of the pain. They're related to the expression of the pain. If I take an example from people again, I suppose, human pain human pain-related behaviour is programmed on a cultural basis. So that what you do when you're in pain depends very much on the culture that you grew up in and what it's normal for you to do. If you take two African people, one from the east of Africa, the east coast of Africa, and one, say, from the north of America, from Chicago, or from one of the cities in North America, their pain-related behaviour will be very different. If you look on videos of the kind of things that go on in East Africa and you look for people who are in pain, they'll usually be sitting quietly in a corner, huddled up, not making any vocalizations, in a very sort of hunched posture. And if you go for somebody who's genetically very similar but happens to live in North America, when they feel pain, they'll be shouting at people, they'll be running around, they'll be threatening to shoot people, they'll be very aggressive and very upfront about it. They're not feeling a different degree of pain, they're expressing their pain differently. So for our species, you need to be aware of what those animals are used to, where they come from, and what pain usually looks like in those populations of animals. Very often, animals will show altered eating and drinking. It's common for rodents not to eat and drink as much post-operatively as they do pre-operatively, and that's been shown to be associated with pain. If you give them appropriate analgesia, then their eating and drinking isn't affected nearly as much. And interestingly, rats and mice are so poor at showing pain-related behaviour that until very recently, altered eating and drinking was the best measure that many people had that these animals were in pain post-operatively. And people would go round and measure the weight of their animals and the food consumption of their animals post-operatively as a way of assuring themselves that these animals weren't in pain. And another thing that animals do, that we do as well, particularly with persistent pain, but also to a lesser extent with acute pain, is we get depressed. We get miserable, we go and hide ourselves in a corner, and we just don't behave normally. This is a very unselfconsciously human diagram because I want to talk about referred pain. We've spoken a lot about somatotopic localization and about how you have parts of the central nervous system which are related to parts of the body and which receive sensation from different parts of the body. And the whole of those somatotopic maps that I've shown you have been somatic. They've been the surface of the body, in different areas of the surface of the body. We have a very poor mind picture of the insides of our body. And if I were to ask you, where is your stomach, and you hadn't read an anatomy book, you'd have a very poor idea of where your stomach might be. You might be able to say, well, it's somewhere down in the abdomen, but you might say it's here, or here, or here. And if you know that your stomach's around about here, that's probably only because you've seen that in a textbook. It's not because you've got any feeling for where your stomach is. Because we don't have a very good picture of where the internal organs are, when those internal organs cause pain, that pain tends to be felt over part of the surface of the body, which is not necessarily related to where that structure is inside the body. And we call that referred pain. And medical doctors can use referred pain as a means of aiding with diagnosis about where the origin of the pain is. I'm sure you're all aware of the story of the middle-aged businessman who maybe has a bit too much for lunch one day and gets a very severe pain shooting down his left forearm from his shoulder, and gets very excited about angina and about the state of his heart, and fetches up at the local intensive care unit and says, I need an ECG, I think I've had a heart attack, I feel miserable, I'm going to die. And that's because everybody knows that angina pain radiates down both forearms, in fact, usually the left forearm, but also the right forearm. Unfortunately, in blue here, esophageal pain has a very similar referred picture. And so many of those businessmen that have that business lunch and then fetch up in the emergency room very often find out that it was just too much of a nice lunch and they've had a bit of reflux esophagitis and it's esophageal pain that they're feeling and not cardiac pain. But the point is that in people at least we can infer from where the pain is felt to where the pathology might be. So that if you feel a pain in your groin, and I'm told it's a very severe and unpleasant pain, that is suggestive that the pain comes from the ureters. Ureteric pain is felt in the groin. And pain from the kidneys is felt in the lower back to either side of the midline. So that if you go around and you've got kidney pain, you're kind of going, oh, that's sore, and feeling it in the middle of your back. Now, we can't be sure about referred pain in our species because, we can't find out where animals are feeling pain because they can't tell us. But we do see pain-related behaviour that may well be due to referred pain. For example, horses that have abdominal pain will very often do a behaviour known as flank watching. And they will sit in their boxes and they will gaze round at their side for a long period of time, for ages. And if you see a horse doing that, you can be fairly sure that it's got abdominal pain, because that's a specific and known pain-related behaviour. Dogs that have anal pain, usually from infected anal glands, will very often lick and chew at their forearms. And it's not because they can't lick and chew at their backsides, because most of you that have had dogs will know that most dogs are very happily capable of licking and chewing at their backsides if they want to. But they'll sit there and they'll gnaw and lick and chew at their forearms. It may be that the pain is referring to their forearms, and that's a specific behaviour that we see that's associated with rectal and anal pain in the dog. Okay, let's talk about monitoring for pain. Three big questions: when to monitor, how to monitor, who should be doing the monitoring. And I hope that what I've said so far will give you an indication of the answer to those questions. Okay, when is the best time to monitor for pain? Okay, the best time to start looking for pain is when you have an animal that you know isn't in pain, because then you'll see their normal behaviour and you'll see what the animal's like. So if you have an animal that's coming into the veterinary surgery for routine surgery, it's a really good investment of time to get to know that animal as it comes in through the door. To see what kind of behaviours it expresses. Is it a bright, bouncy dog? Is it a nervous dog? Does it hang back? Is it a little bit cowed? What kind of behaviours would we expect this animal to be showing when it's in pain? And what's its normal behaviour like, so that when it's in pain post-operatively, or when it may be in pain post-operatively, we know where we're aiming for, we know what the normal is. There are various ways of monitoring for pain, and I'll talk to you about a couple of them. But one of the most important things to say about monitoring for pain is be interactive with the animals. Approach them, tickle them behind the ears, play with them, and see how they respond to that. Because if an animal is in pain, it might not be showing you that it's in pain, but it may well not respond normally to a tickle behind the ears. Instead of tickling behind the ears and going, oh yeah, that's nice, you may get, oh, go away, I'm not interested. You'll get a change in its behaviour. The last thing to say about monitoring is the person that should be monitoring. The person that should be monitoring is the person that's having the most to do with the animal for the longest time. And mostly in veterinary practices that will be the vet nurse, because the vet nurse will be the person who's monitoring in the recovery period, the person who's in the kennels when the animals are in the kennels. So it's good to train your nurses to look at animals when they're wandering around the kennels and just have in their mind the whole time, is that animal's behaviour normal? And if it's not normal, why is it not normal? Might it be in pain? The best way to encourage that kind of environment is to give the nurses a little bit of ongoing training about pain, and always to take any feedback you get from them about animal pain seriously. You'll see when you work with nurses that just like the rest of us, they're different people. And there may be a nurse in a practice who is very concerned about pain and who thinks that many of the animals are in pain post-operatively and is always coming to you about pain. And there may be another nurse in the practice who is a little bit more blasé about pain and, doesn't often come and see you and doesn't notice mild to moderate pain quite so much. And you will know where those nurses are in their sort of place on the spectrum, but you need to take their requests seriously, because you don't want to belittle the keen nurses' views on pain so that they dry up and stop telling you about what's going on, because you need that information to come back to you. But at the same time, if you do get the other nurse coming to tell you about pain, you need to take it very seriously, because the chances are that's the most painful animal that's been through your kennel room that month. There are many, many, many ways of monitoring for pain-related behaviour. I'm going to talk to you about 3. The first 2, the simple descriptive scale and the visual analogue scale, are things that you might want to use in a practice situation. The multifactorial pain scale is a little bit more involved, takes more time, and is more of a research tool. We tend to find it's very powerful for pain-related behaviour in a research setting, but it's not the kind of thing that most people will use in practice, because it just takes too much time and is too complicated to administer. First of all then, the simple descriptive scale. You assign a number, usually from 0 to 5, because it's actually quite difficult to grade things on more than a 5-point scale. It tends to get a little bit subtle. If you try and grade it on a 10-point scale, you'll find that you're thinking to yourself, is that a 7 or an 8? Is that a 3 or a 2? What's going on here? If you put it on a 5-point scale like this, then you'll find that it's much easier to decide what's going on. And to each of those points on the scale, you attach a descriptor. And it's best to keep the descriptor as simple as possible. So, for example, a 0 is no pain. A 1 is occasional mild pain, or mild pain at 2, moderate pain, severe pain, and intractable pain. It doesn't really matter what those descriptors are, as long as everybody has a picture in their mind of those descriptors. And then when you assess the animal, you write down on its clinical record the number that corresponds to the description of its pain. A visual analogue scale is similar, but not quite the same. Here you have a line, and it's usually a 10 centimetre line on a piece of paper. You attribute no pain at one end of the line and the worst imaginable pain at the other end of the line, and then you make a mark on the line. Oops, didn't do it on this one. And then you make a mark on the line at a point where you think that animal's pain is. And then because it's a 10 centimetre line, you can measure from the no pain end how far along the line the mark is, and you can say that this animal's pain is, I don't know, 5.3 or something along those lines, or 53% of the way along the line. Advantages and disadvantages. This one is much easier to do and much more straightforward. It needs a little bit of training, and importantly, it doesn't need a separate piece of paper with lines drawn on it. So you've got fewer sheets of paper following the animal through the clinic. The disadvantage is that it tends to lump pain together, so it loses a little bit of sensitivity, so that you will have a picture in your mind of a spectrum of pain that is moderate pain, and then a spectrum of pain that is severe pain, and you might find that animals fit somewhere between those two. There's no way of giving a half pain score with these. It's just a number that attaches to a description. This one, the advantages and disadvantages obviously are reversed. You need an extra sheet of paper to follow the animal through the clinic. You need less training to be able to do this than you do for the simple pain scale. And also you don't tend to group. Because there are no marks on this line at all, you don't tend to have that Is it a 3 or is it a 4? It can easily be a 3.75 and nobody's very concerned about that. If you want to look in detail at multifactorial pain scales, then I suggest you look at one or both of these two references, and they will give you an insight into what's going on and how these things are used. This is an example of an ethogram which will be developed into a multifactorial pain scale, which is being developed into a multifactorial pain scale. And it's from Jill Price's work, looking at horses. What Jill's done here is she's videoed horses for a period of time, usually for an hour, 24 hours before surgery, in the first 24 hours after surgery, and the next day. And she's looked at the amount of time that the animal is showing different behaviours. For example, the animal standing with its head above its withers. 40% of the time pre-surgery, 39% of the time the next day, 37% of the time the day after. So that's not a good indicator of pain. Let's try and find one that is a good indicator of pain on here. Amount of time spent in lateral recumbency. 1.6 here, 0 here, and 3 here. So here's an animal that before surgery is spending some of its time in lateral, doesn't lie down at all on the day after surgery, presumably because it's a bit sore, and then the day after that lies down a lot more, presumably because it's tired because it didn't lie down the day before. So we're looking at specific behavioural indicators which are giving us indications of the amount of pain that a horse might be in, or the amount of pain-related behaviour that the animal is showing. Here's another one, standing in an abnormal position, not at all the day before surgery, 4 times in an hour the day of surgery, and only once in an hour the day after surgery. So specific behaviours that animals are showing. What a multifactorial pain scale does is it takes a selection of those behaviours and gets you to score the animal's behaviour using each of those behaviours, adds those together and gives you a final pain score, which might be on a scale of 0 to 25 or something like that, and then tells you whether that equates to no pain, mild pain, moderate pain, severe pain. But it's a little bit cumbersome and it takes a little bit of hard work to do that. Okay, what other research methodologies have we got to look at pain? Well, one of the other research methodologies we've got is to look at the pain threshold and to look at hyper and hypoalgesia post-operatively, which are movements effectively of the pain threshold. This is a device again from Bristol Vet School, which is a pen which pushes a blunt probe into the tissues with an increasing force. It's exactly the same as the thing that we were doing yesterday with the key, except it's measuring the force that it's pushing against the tissue with as it increases the force. It's called a constant rate application of pressure meter, or a prapometer. And here it is being used preoperatively on an animal that's about to undergo surgical ovohysterectomy. So what's happening is we're applying this to the animal and looking for the first sign of pain-related behaviour. The first time the animal looks around and goes, "Whoa, get off, what's that?" And then, in a serial sense, post-operatively, applying this again to usually the area of the abdomen and also to several sites away from the area of the wound, and looking at how the surgical procedure and the analgesic drugs that the animal has had alters the pain threshold. And in that way we can compare different analgesic agents to each other for different procedures. Here's an example of a study looking at pain thresholds. This is a study done by Redua et al. And it actually compares spinal ketamine to spinal saline on the pain thresholds generated around the pudenda of a horse. it was suggested a few years ago that ketamine would be a good analgesic for back-end surgery in horses if it was given spinally. And obviously saline isn't going to be an analgesic. So what this study does was it compared the thresholds giving the two drugs to see which ones gave the increased threshold. And an increased pressure before you get a pain response is obviously a reduced threshold and demonstrates analgesic effect. And you can see here that throughout the period of the study, these animals, the animals that had ketamine spinally, were showing increased pain thresholds, i.e. analgesia, compared to the animals that had saline. So that's a research way in which we can use pain thresholds to assess pain and different analgesic techniques. We can look at the stress response as a way of assessing analgesia. We can look at tachycardia, hypertension, sodium retention, altered metabolism, and cortisol. All the things that I was telling you about last week that are factors in the stress response. For the most part, in a research setting, people use cortisol because it's easy to measure and you can attach a number to it and you can do stats on it. Here's a paper, Richardson et al., looking at cortisol. This time, is local anaesthesia for flank laparotomy in a cow a better analgesic when given by the epidural route or when given by the paravertebral route, which is blocking the spinal nerves as they come out from the spinal cord in the lumbar region? You can see that when you do an epidural anaesthetic in fill dots and then do a flank laparotomy, you get a bigger increase in cortisol over the next hour than you do if you've given a paravertebral local block. And so it's concluded from this that paravertebral analgesia is better, it's a better analgesic than epidural analgesia for flank laparotomy in the cow. And you see how we're drawing those conclusions about real-world situations from things that we can measure. Something that I'm quite interested in is looking at the electrical activity of the brain and using that to infer about the pain that an animal might be suffering. We can look at various EEG factors such as the medium frequency and also the spectral edge frequency, and event-related potentials like somatosensory evoked potentials, and look at how those change with different procedures to infer things about pain that animals might be in. The advantage of this technique is that we can do this in anaesthetised animals. So we can look at pain perception in animals without actually causing them any pain because they're anaesthetised. This is a pony's brain, and this is the electrical activity generated by not this brain, because this brain had been in a pot for rather a long time, but by the brain of a pony still in a pony. And this is an anaesthetised pony. Can you see in the middle that there's a change in that waveform? Is that obvious to everybody? Yeah, it gets more wiggly suddenly. The nice thing about this is that this is a pony that's very lightly anaesthetised, only just anaesthetised, and this is the instantaneous change that you get 1 circulation time after you give an intravenous anaesthetic agent. So what we're demonstrating here is that these EEG changes change with no time lag instantaneously with changes in brain function, either caused by anaesthetic agents or also we're finding now caused by noxious stimulation. The problem with this is it's just a wiggly line, and you can't exactly write in the literature the line got more wiggly because, you know, the referees don't like that. Vet record, Johnson et al., it got more wiggly, doesn't come much ice. So what we do is we do mathematical techniques on this to try and define the amount of wiggliness of the line. This is a thing called a power spectrum. I'm not going to bore you with how we derive that, but it basically is saying what is the power in that waveform at different frequencies. How wiggly is the line at low frequencies and how wiggly is the line at high frequencies. And the nice thing about that is that then we can generate numbers from it. We can look at the median frequency, the frequency at which half of the wiggliness is below that frequency and half of the wiggliness is above that frequency, and we can see changes. This is Jeremy. think I showed you a slide of Jeremy last year. Jeremy was a postgraduate student of mine at Bristol a number of years ago now, and he was looking at perfusion in tissues and ways of measuring perfusion in tissues. And we decided that a good way of altering the perfusion in Jeremy's hand was for him to stick his hand in a bucket of salted ice so that he could reduce the perfusion. He could last about 20 minutes, and this photo was taken about 2 minutes before his sense of humour failure, where he said, right, enough, I'm not keeping it in there anymore. But it's interesting because it reflects a study that was done about 15 years ago now by Chen and colleagues, who took volunteers and got them to immerse both arms in salted ice water at about -4 degrees C while they recorded their EEGs as a model of pain. That's quite a painful thing to do. If you take your arms and stick them both into really icy water, it's actually painful. And he found that the volunteers in this study divided into two groups. There was a group of volunteers who could do that for 2 minutes. Yeah, I'll do that for you. Stick it into and manage 2 minutes. And there was a second group who did it for 20 seconds, took their arms out and said, no study is worth that much, I'm off. And he called them the high pain threshold and low pain threshold volunteers and divided them into two groups. When he looked at their EEGs, and again this is a slightly differently derived frequency histogram, but the same thing, he found that in the middle frequencies, where the median frequency is recorded, there was a bigger change in the EEG in the low threshold volunteers, the ones who couldn't stand 2 minutes, than there was in the high threshold volunteers. And so what we seem to have here with the EEG changes is a pattern that's not associated with the magnitude of the stimulus, because the stimulus was the same in both groups, but it's associated with the degree of perceived pain. That's really important because it's becoming apparent now that the perception of pain in a given patient or volunteer in a study has more to do with their central nervous system than it does to do with the magnitude of pain. And if I draw you an example of that, imagine the pain associated with having a tooth pulled out. Yep, certain number of C fibres in your tooth, the tooth's pulled out and they all go, ouch, that hurt, and send that magnitude of stimulus into the central nervous system to be perceived as pain. Now if you're playing a good rough game of rugby and somebody accidentally knocks one of your teeth out, well of course it would be an accident, wouldn't it? It's a sport. If somebody accidentally knocks one of your teeth out, it doesn't always feel that painful, I'm told. Yeah, some people have had teeth knocked out in a rugby game and not noticed until they've got into the changing room afterwards. I had a friend when I was at university who was playing soccer and went up for a header with somebody else who went up for the header and had one of his teeth half knocked out, and it was punched through his lower lip and it kind of came out the side and he couldn't open his mouth. And he didn't notice that this had happened. All he noticed was it was a bit harder to breathe and shout at his mates because, you know, he didn't actually perceive very much pain from it because of the state of his central nervous system when he perceived that pain. Now imagine somebody that's captured as a political prisoner and has 3 days of torture and sensory deprivation, and then someone comes in with a pair of pliers and pulls a tooth out. That's extremely painful and unpleasant, and one of the nastiest things you can do to people. The magnitude of the stimulus is the same. They lost a tooth. But because of the states of their central nervous system, when they received that, the degree of pain that they perceive is very different. So, when we're measuring the electroencephalographic changes with pain, we think we're measuring the perception of pain by the animal rather than the magnitude of the stimulus. This is a study done by a PhD student of mine looking at changes in the median frequency with castration in horses. The baseline technique here is a technique of general anaesthesia that doesn't involve any analgesic drugs, any pain-relieving drugs. The horses in this group weren't giving any pain-relieving drugs until just before they woke up from anaesthesia, after we collected the data. And you can see that the median frequency increases when testicle 1 is removed and increases when testicle 2 is removed compared to the baseline. And in groups where we gave either alfentanil, which is a potent opioid, a morphine-like drug, or lidocaine, which is a local anaesthetic, which is sometimes given intravenously to horses, we either got no response to the removal of the testicles or a very reduced response in the case of lidocaine to removal of the testicles. And so we've demonstrated in horses and in many other animals now that this median frequency increase is a good indicator of visceral noxious stimulation. And we're beginning to use that now in applied research, looking at things in the field. This is a deer, one of our study deer. You can see it's anaesthetised and it's got EEG electrodes attached. But it's a deer that's about to have its antler removed. You probably know that velvet antler is removed from animals in New Zealand on a yearly basis and is used in the nutraceutical or health food market in the Western world, and also as a Chinese medical remedy in the sort of Far East. The United States Federal Drug Administration a few years ago suggested that one of the metabolites of lignocaine, the local anaesthetic that's most commonly used to render the antler analgesic before the antler is taken off, had metabolites which may be carcinogenic. And the deer industry in New Zealand went, oh my word, all these health food people aren't going to want our deer antler if they think it's got a carcinogen in it. And so they've been very busily looking for alternative means of providing analgesia. And somebody suggested that if you take a rubber band and you tighten it around the antler with what is effectively a fence wire tensioner and make it very tight, that not only doesn't hurt the deer, but is analgesic, and 4 minutes later when you take the antler off, the deer doesn't feel it. And they did a lot of behavioural studies where they did this to deer and they took the antler off and they videoed them, and the deer showed absolutely no pain-related behaviour. But remember what I said before about deer being hunted animals that don't show pain-related behaviour? Deer are one of the hardest of the veterinary species that we deal with to see pain-related behaviour. So those deer were going while their antlers were taken off, and we didn't actually know if that was because this doesn't hurt, or, ooh, that hurts, but I can't show anybody, and I can't even do that without showing pain-related behaviour in my face. But deer are very impassive. So we assessed this, and we looked at EEG changes in 3 groups of deer. One group was the control group of deer, one group was the group of deer that had compression, and one group had lidocaine, the standard nerve block, ring block actually. And this is the period 2 minutes after antler removal. So antler removal is here, and this is the EEG change in the next 2 minutes. And if you compare the gold standard, local anaesthetic, you get absolutely no response to the antler being taken off. Local anaesthetic is a good analgesic. If you look at the control, you get this huge increase in medium frequency, and this is one of the biggest increases in medium frequency that I've seen in any of our data sets. Okay? Not surprisingly, if you anaesthetise a deer and then take its antler off with a saw, that's quite stimulating. The compression group is in the middle. It causes some analgesia, but the analgesia is not as good as a local anaesthetic ring block. Interestingly, we took data 4 minutes before this, when either a local anaesthetic ring block or the compression band was placed. And we found that local anaesthetic ring block caused no increase in EEG when it was placed. It didn't sting the animals at all to place that. But the placing of this compression band caused an increase in the EEG, pain-related variables, which was as large as taking the antler off with no analgesia. So what we're saying is that applying this band to the antler pedicle is as painful as just taking the antler off with a saw, and they still feel it a little bit when you take the antler off with the saw. And on the basis of this, a technique that was about to be approved by the animal industries and by the government in New Zealand wasn't approved and now isn't used on deer. So I just wanted to use that as an example of how we're using research techniques to feed back into the real world to improve the way that we deal with animals in husbandry situations. A few words on pain therapy. Various chapters from this book are on your reading list. It's an excellent little book for various reasons. It's not that expensive, which is a good thing. It's written by people that know what they're talking about. Professors Paul Flecknell and Avril Waterman Pearson are the editors. Another good thing. And it's quite small. It can fit into your pocket. It's quite cheap. So it's a good little book, and I would recommend it to you. What kind of things can we do for pain therapy? Oh yes, another reason why it's a good book, it's in the library if you can find it. Well, the thing that we all tend to reach for as veterinary surgeons, or at least I tend to reach for as veterinary surgeons, are drugs. Yep, this animal is in pain. I've got some drugs in my pharmacopoeia that are analgesics. I'm going to fill this animal with one of these drugs and its pain will go away. Drugs are important, but they're not the only pain therapy that's effective in animals. Preemptive therapy is important. We've talked a lot yesterday and today about the state of the central nervous system that's receiving the painful stimuli. And if you cause somebody or something pain, its central nervous system actually becomes more receptive to pain in the future. So a good time to start pain relief is actually before the animal has anything painful done to it. And so it's common to give pain relieving drugs to animals that are having surgery with the sedatives that they get before they go to surgery. Or if you get an animal that comes into the surgery and it's got a painful abscess and you're going to drain the abscess the next day, give it some pain relief into the intervening 24 hours and it will suffer less pain post-operatively than it otherwise would. Physical therapy is useful. Again, if you've got a sore ankle, I was saying yesterday that the next day the ankle might be actually painful to walk on. But if you persist a little bit and you just walk round and you move the ankle and exercise it, gradually that pain goes away. And in the same way, physical therapy and flexion and movement for animals can be a very good analgesic technique, or augmenting other analgesic techniques. Surgery itself can be analgesic, and again, using the example of an abscess, if you've got an abscess and it's very painful, one of the best ways to relieve that pain is to cut the abscess out. Take away all those nasty icosanoids, and the animal's suddenly much more pain-free. Psychological therapy is important for people and for animals. Just simple things like, here's an animal in a kennel, I know I'll take it round the block for 5 minutes on a lead and let it have a pee on a piece of grass and just let it sniff a tree and do some of the normal things that dogs do, if it's a dog. Don't do that if it's a cat. It's going to feel much better about itself, and its pain, its perceived pain, is going to go down, its pain-related behaviour is going to go down, just because you've made it feel better about life and made it feel that, you know, maybe life is worth living, maybe I'm not going to be stuck in this cage forever. And at the end of the day, don't forget euthanasia. Euthanasia is the ultimate pain control. A lot of people, vets and lay people, tend to look at euthanasia as what you do when therapy's failed. Yeah, when you've had a real disaster and everything's gone wrong, well, put the animal to sleep. But actually, if it's done right, euthanasia can be a positive management step in dealing with an animal's disease. If you can talk to the owners and get the owners prepared for it and take them through the process and give the animal a much more comfortable and pleasant death, if death can ever be pleasant, than it would have if it died in pain of its disease process, then you've done the animal a service, you've done the owners a service. Owners that have animals which are euthanized in a relatively pleasant sense tend to be owners that are keen to go out and get another pet in the future. Owners that have had a pet and really don't want another one are very often owners where at the end of the pet's life it's suffered for a protracted period, there have been problems with the euthanasia, things have gone wrong. So euthanasia is one of the most important things for you to be able to manage well, certainly in companion animal practice. You'll get plenty on multimodal analgesia in your pharmacology notes next year. We've talked about preemptive analgesia. I just want to say a little bit about alternative therapies. Alternative therapies are something which have traditionally in veterinary medicine been in the wild and wacky bin, and people haven't really known very much about them, nor wanted to, and haven't believed very much about them. But in terms of analgesia, there's an increasing body of evidence that some alternative therapies, like acupuncture, can actually be quite pain relieving. And so I'm not suggesting that you all go out and get into veterinary acupuncture, but it may be that if you've got an owner that asks you about acupuncture as pain relief, they're not quite as left field and quite as wacky as you thought they would be. And it might be worth looking into referring them to somebody that does veterinary acupuncture. Even if it's not effective as a therapy on its own, then it can be effective as a psychological therapy, because the animal that's getting acupuncture is getting lots of attention, he's going on a special car trip to the special vets, getting tickled and prodded and think, oh, this is all right. So they're at least getting physical therapy, and they might actually be getting something that's useful.